I got ADHD, baby. I set my goals, not your expectations, baby. I need my tools and a brain vacation, baby. Neurodivergent flow, no limitation, baby.
Thank you so much for joining me in this conversation. So everybody that is listening, we are going to be talking about chronic pain and ADHD, and we have Dr. Lenz here, and he is going to give us all the ins and outs around the relationship between ADHD and chronic pain. And so I'm really excited to have him here. And if you don't know me, I am Megan Brown-Enya. I am the owner and operator of ADHD at Work, where I serve women with ADHD and allow them to define success and help them get there. And so, Dr. Lenz, I'm going to have you introduce yourself because you have so many accolades and you do so much that there's no way that my working memory is going to allow me to remember it all.
Well, thanks so much for having. We're both on the special interest group for APSAR, American Professional Society for ADHD and Related Disorders. That's how we got connected not that long ago. And my background, I'm a pediatrician. I've been a doctor for 26 years and pediatrician, as well as an internist. I also got certified in clinical lipidology, which is how to prevent heart attacks, strokes, and also lifestyle medicine. So I kind of take a holistic, evidence-based approach to help people live a quality life. I was blessed to have my first year in med school in 1992. It was an optional noon lecture by an ADHD expert in Milwaukee, Wisconsin. I don't know who it was, but I think it was Dr. Russell Barkley, because he was probably in it at the same time. And of course, if I would have known it was going to be this famous person, I would have been, before his books and all of this. But I'm pretty sure it was him, and I didn't understand. And then in my residency from 96 to 2000, which was a combined, where I do both pediatrics and internal medicine combined, where you do a peds clinic and internal medicine. My supervising doctors, it was routine for us to be evaluating for, diagnosing, and treating ADHD in kids. Not in adults, because that wasn't even thought of and wasn't discussed at the clinic. But having taken care of kids that grew up and keeping up to date, realizing, well, this never did go away. And now the research is supporting my clinical experience that adults get this. When my 14-year-old patients become 24, they still have it. And now I have patients that are diagnosed at age 20, 37 years old now, still treating and still making a huge difference. And then I work I used to do both inpatient and outpatient with the world of hospitalists and stuff. I switched to all just primary care in the last several years, working just in a clinic. I work in the Milwaukee, southeastern Wisconsin area. I see patients within Wisconsin, although occasionally I have people wanting to travel from the surrounding areas just to see me, because there aren't too many doctors that treat complex chronic pain problems with a holistic, evidence-based approach. And then I wrote a book that got published just 4 years ago called Conquering Your Fibromyalgia. Part of it was because I used to have a 2-page handout on fibromyalgia and then a 20-page handout, and that wasn't enough. And I thought, well, maybe I should write a book. And then COVID hit, and well, I don't know, there's nothing else to do. And when there was nothing else to do, I got to get this book done. So I finished that. And then I was done. My wife said, "Are you done?" And I said, "Yeah, I think so." My brother had a podcast unrelated to any medical things, and made me think about it. And then 6 months after the book got published, I said, well, I should start a podcast. So I've been doing a podcast for 3.5 years, once a week, where we discuss chronic pain and overlapping related issues and fibromyalgia, Ehlers-Danlos, POTS, mast cell activation syndrome, chronic migraines, headaches, chronic back pain, pain that's going on for 3 months, often associated with other co-overlapping conditions like poor sleep, fatigue, brain fog, cognitive struggles. And so that's a quick summary of my background, and more could be said, but
No, that's great. And this is why I had you on here, right? And this is also why I had you introduce yourself. Because you have done such amazing work, and you're doing such amazing work, and contributing to a field of study that is like, there's not a lot of people doing this. And it's such an important topic, because the chronic pain experience is one that a lot of us deal with. And that could, like in what you said, like that could be anything from dealing with just back pain, putting my hand up for that, or but also as a woman, and like there's a lot of women that are experiencing PMDD too,
Yes.
and monthly.
Hmm.
And so it's good to be able to have those conversations and the connections, and just to have a deeper dive conversation about how this even connects to ADHD and what the impacts of it are in both ends. But then also, I'm all about ADHD and work, and like and how this connects with you being able to be successful in the workplace if you're experiencing chronic pain, but also trying to be productive.
Yeah. So you're right, adding PMDD, premenstrual dysphoric disorder, um, throw into that endometriosis, chronic pelvic
Mhm.
pain, vulvodynia, um, uh, chronic pelvic pain. All of these are part of that. What I've realized that from a clinical experience, I was seeing these overlapping conditions. You might have back pain, your sister has migraines, you both had painful periods that you learned to stop complaining about because who wants to hear that you're in severe pain every
Very much.
month for a couple of days? So you didn't, the pain doesn't go away, you stop complaining. And then often, for many people, sadly, there can be, you get neck pain, and next thing you know, you're hurt everywhere. And
Mhm.
you get invalidated by many doctor encounters and medical encounters that you're, one sense, they reassure you you don't have lupus, you don't have rheumatoid arthritis, you look pretty normal, just
Right.
take some Motrin, and then there's nothing else to do. I never believed in hypochondria going into med school. I knew there was something going on, and often when you look at people in extended family, recognizing that it touches somewhere in most people's family tree. You remember social gatherings of people who had struggles, and you didn't know the name of it. And as a young person trying to grow and understand, helping
Right.
people, you remember those, and that brought that forth to others. But what I realized is there were also these overlapping from clinical experience. Many of my patients I was recognizing in adult ADHD also struggled with these chronic pain conditions. And so by intuition and by just experience, you start asking about that. Now, that's not uncommon in medicine where we have these co-occurring conditions, right? There's a condition called atrial fibrillation, a heart rhythm problem. Now we know maybe about half of people who have that have sleep apnea. So
Mhm.
we just think, oh, let me ask about snoring. Now, one of the things that I've realized is that you think of ADHD and why does a child get recognized? It's usually because of academic distress, right? That's often the problem. And one of the things for many adults, who have unrecognized and untreated or suboptimally treated ADHD, what often brings them to the doctor, sometimes it's their child gets diagnosed, right? Sometimes they're going back in life, like a recent patient I saw today who is a medical assistant, but now trying to get her LPN and nursing degree and is struggling academically and recognizes, hey, my child has this, I guess I have this, and get referred to me to get evaluated. But for many people, it's actually the symptom that brings them in is a chronic pain syndrome, not always academics. Now, that might be the chief complaint to the doctor. I
Yeah.
get migraines that are frequent. I have terrible pelvic pain. All of these. And if you can just recognize that these often commonly co-occur. You
Mhm.
talk about PMDD. I was just at the APSARD conference, American Professional Society for ADHD, great conference, and they had 2 hour-and-a-half sessions in the morning that dealt with um, uh, ADHD in women and the connection with hormones. And I think it was Dr. Lotta Skoglund mentioned how when you look at what are the PMS symptoms,
Mhm.
those are almost like the same symptoms we would be talking about for ADHD, right? And really, for many, if we just potentially including that,
Mhm.
because women may not have as many the intensity of symptoms may not be as severe, except into that luteal phase, that week or two before a period when estrogen levels drop. Estrogen affects dopamine expression and transmission, and so there can be intensity of symptoms. So there's that recent, just discussion at the conference a week and a half ago. But then as studies started coming out, there was a study out of South Africa that found 47% or so of people who had fibromyalgia just met the World Health Organization ADHD screening for having uh, uh, also ADHD. And those screeners can underestimate that. People may minimize a symptom, right? Oh, I don't have that. Oh, but when you rephrase it, when you take a more examples, to like I used the DIVA questionnaire.
Mhm.
That's I got a Dr. Kuhi from the Netherlands was at this conference, got a chance to talk with her, and
Oh,
often
nice.
you have a chance to dive a little deeper to really understand that there are other symptoms may be dismissed. So the studies have shown between about 30 to 80% of people with chronic pain syndromes have ADHD.
You said 30 to what?
About up to 80%, depending on the study.
Wow. Wow. 30 to 80% with people with experienced chronic pain also have ADHD.
Yeah, and most of these were people. There was a big study out of Japan and Tokyo, University of Tokyo pain clinic, and they had people who they call it somatoform pain disorder, which was under a psychiatric diagnosis, which really overlaps with what we call chronic fatigue syndrome, chronic pain. But um, they did evaluated like it was over 153 consecutive patients and then screened them for ADHD, and it was 73% in this study met criteria for having ADHD.
Wow.
Do you know how many, these were adults, of course. Do you know how many previously were diagnosed with ADHD?
Probably zero.
Zero. And probably would be a similar in the States. So then what they did is they asked people, hey, would you like to be treated? About 60%, I think, of those agreed to try treatment, and that was either methylphenidate or atomoxetine, which is a non-stimulant. And what they found was when you look at their pain scale, that 0 to 10 pain scale, it dropped 60% when they were treated.
Wow.
And there's other studies showing that. Dr. Joel Young, who also met at the conference, he had a study there showing in their clinic where they evaluate, and he is a psychiatrist who's done work with chronic fatigue syndrome. Chronic fatigue syndrome is basically another name for me, in my opinion, most people, for fibromyalgia. It's pain, fatigue, brain fog, cognitive dysfunction, etc. And in those who had ADHD, or they treated, and they found there was a marked improvement in pain and fatigue, as well as cognitive function, executive functioning skills in those patients. He has a study now at the conference, excuse me, in their clinic where they're evaluating the most common diagnosis of all the or the psychiatric diagnoses in their clinic, including CFS, was chronic fatigue syndrome that came to a psychiatric clinic. Now, I'm going to be interviewing him in a couple weeks, but of those, I calculated there was 57% of those who had chronic fatigue syndrome, they also had a co-occurring ADHD. So again, more data supporting that. And he has a study that he's doing now with I forget the brand name of this. It's a longer acting form of dextroamphetamine that lasts closer to 16 hours, looking at, I don't know if it's 50 patients or so they have enrolled, and hopefully will again affirm what other studies have shown. Like, hey, if you have ADHD and you have chronic pain, treating your ADHD is actually a huge part of that.
Yeah. So my mind is completely blown right now. So, what I'm really hearing is there's a direct connection between chronic pain and ADHD. And ADHD numbers and the number of people with ADHD out here in the world is there's just not a lot of people that are being counted. So there's probably more people with ADHD than we're currently recognizing, because it seems like there's a lot of people recognizing they're experiencing chronic pain.
Yeah, a lot of people are coming to the doctor. I think there was a stat I think I heard at the conference. People with ADHD are 10 times more likely to go to the doctor. And I think often what their complaint is not academic struggles, but often it's one of these distress symptoms. And I kind of
Mhm.
lump two types of distress symptoms: anxiety and pain. The definition I like to use for anxiety is the perception of a real or perceived threat, right?
Mhm.
And you can have a soldier who has trauma exposure, PTSD, they're in a safe place, but they still may hear a noise or sounds or hear things and think that there's a real threat. But it's perception, right? They're safe as best we can say. Pain is the perception of a real or perceived tissue damage,
Mm-hmm.
which we kind of intuitively think isn't pain a marker of a tissue damage, an injury occurring. A quick
Mm-hmm.
little background on the three categories of pain. There's three types of pain. This is relatively new in the last 2 years, but nociceptive pain is the pain that has to deal with tissue damage, right? So you have an appendicitis, you're having ischemia, lack of blood flow to your heart for a heart attack, you broke an ankle. Those are what we think of classic tissue damage or nociceptive pain. There's another type of pain that's called neuropathic. The most common would be like diabetic neuropathy. You have nerves that are injured, blood sugar coating over decades, damaging that. There are some autoimmune issues that can cause injury to peripheral nerves. And you can also have like a pushed on a herniated disc that's causing that. And then there's what's called nociplastic pain. Nociplastic pain is pain that's going on for more than 3 months. And there is also associated pain with a fatigue, brain fog, and insomnia typically associated with that. And there isn't tissue damage, or if there is tissue damage, the pain is out of proportion to the amount of damage. And so under that umbrella includes things like regional pain, things like PMDD,
Mm-hmm.
dysmenorrhea, chronic back pain, atypical chest pain that often maybe people say, oh, you have chest pain, you go to the doctor,
Yeah.
but it's not. But, chronic migraines, tension headaches, irritable bowel syndrome, irritable bladder or interstitial cystitis, disorder of the gut-brain interaction, which is chronic
Yeah.
dyspepsia, overlapping mast cell activation, chronic fatigue, fibromyalgia. All of those is like multiple, adding up. I call fibros the 5-alarm fire. Low back pain is the 1-alarm fire, or IBS is the 1 alarm, but you can have often multiple of these overlapping.
Thank you. Thank you for sharing that. Part of my own story is, I like to come onto these lives and just tell my business. And so, part of my own story too is just dealing with chronic pain. Like I deal with chronic lower back and mid back pain. I have since I was a teenager. But I didn't get diagnosed with ADHD until I was 38. And that was several years after dealing with that. And literally no one had a conversation with me. I've been going to the doctors for my back since I was a teenager. And the connection between the chronic pain and other behaviors in ADHD never came up in conversation. And so I'm glad that there are medical professionals out there, even though it seems like it's very few, are knowledgeable in this connection and can ask the right questions so that people can get supports earlier. It says, can we get the spelling of all those different types of pain?
Yeah. So it is the two of them are NOCI, so noci, which is a word for like in Latin for pain, NOCI, and then plastic, NOCIPLASTIC, nociplastic, and noci, and then septive, CEPTIVE, and then it's just neuropathic, and neuro as in neurology, and then yes, nociplastic, and then um, neuro neuropathic as pain, so nerve type pain. And the other thing, just to know, these can overlap. Um, you can have somebody who injured their ankle and somebody who has not neuropathetic but
Oh,
neuropathic.
sorry. It's my
Sometimes
phone
it feels
and the
pathetic.
type. It's my
I
phone.
try
It
to,
it also it the no C to it. It like it changed it to social or something like that
I
too.
know
It's just like a
it's
motto.
yeah, they're not tuned into the dictionary yet for them. Um, so um, when we look at, you mentioned not a lot of people are thinking about it, and that's part of what I've
Hmm.
been just observing this in my practice, and I just like, oh, I should ask about this. Oh, wow, that's a co-occurring issue. And then I just assumed everybody was doing this, everybody was recognizing it, but not
Hmm.
everybody was. And it just was a normal thing. And that's what inspired me to try to share this by writing a book about it. people have done research, but often these are researchers. They may not be integrating into clinical care. So hopefully I can bridge that. I'm going to share a very interesting couple studies that are very similar that I think are just fascinating.
Okay.
They came out about a year ago. Very simple. There's a lot of functional MRI testing done. There was a couple really good, there's a 90-minute talk on PTSD at the conference, which overlaps with anxiety and pain, right?
Mm-hmm.
But a low tech study that was done where they took people who had ADHD, these were adults, and people without ADHD, and they said, we're going to have you put your hand in a bucket of ice water and
Oh,
just hold it in there and tell me when you first report some level of pain, and then pull it out when pain's unbearable. And what they found is that people with ADHD reported pain about twice as fast as those without ADHD. And um, the people with ADHD reported pain twice as fast, and they pulled out their hand about 3 times as fast. And both
oh wow.
when they pulled out their hand, they reported from 0 to 100 their pain. Both groups said it was about 90 out of 100 on average. So their perception of pain was 90 out of 100. So guess what they did in the second half of the study?
I'm not gonna guess.
All right, most
Because
people
I'm not like it.
most people don't guess right, but they gave the people with ADHD Ritalin, methylphenidate, and
Okay.
they repeated it 2 hours later, and there was a 210% increase in how long they could keep their hand in there.
Oh, so you can tolerate pain longer when you treat your ADHD?
Yes, your perception of pain, the threshold is adjusted within 2 hours. Now, imagine if you have that treated all of the time. We know the brain is neuroplastic, which means you can learn to make new connections. That's just a simple, not to add all these noci and neuroplastic and confuse people, but that's just our brain adapting. But imagine if you're daily getting treated in connections, it probably improves over time significantly. Um, and studies show that, like we said, there was a 60% reduction in the one study with methylphenidate in reduction. There was about similar to a 40-50% drop in a study with chronic fatigue syndrome using Vyvanse in those who had ADHD as well. And from clinical experiences, similar. I've had some people who went from severe fibromyalgia, we recognize their ADHD, treat their ADHD, and along with healthy lifestyle, eating a pretty healthy diet, keeping very active naturally where it's completely in the normal range, where it's life changing. Um, and if another, so the similar study, they did it in kids. So we think of trigger points or tender points in fibro where they used to diagnose it by checking spots on your body, and people would report supposedly with 4 kilograms of pressure pain. Well, that's hard to measure. We don't do it anymore, and men aren't generally have as many trigger points. That's why men in the past, they used to think it was 9 times as many women with fibro, and now it's probably a 6-to-4 ratio of women to men, but that's due to trigger point testing. So what they did in kids, there's a special meter called a pain meter or dolorimeter, and they would put pressure on different spots like the forehead, the shoulder, knees, etc. One area they measured, remember the data was, and the kids would say, tell us when you have pain. The kids with ADHD reported pain with like 6 centimeters of pressure on the forehead. Those without ADHD reported like 12 centimeters of pressure of pain before they would report pain. So in this one location of the forehead, it was half as much. Before they would report pain. And again, that's what they did. This time, they gave them methylphenidate, repeated it 2 hours later. This study was done after the study with the bucket of ice water.
Yeah.
And then their pain threshold went from 6 to 11. Didn't quite normalize to a 12, but just the pressure point. So in literally 2 hours of taking something, your pain perception gets affected.
Yeah. I have a follow-up question though. So if you are, and this is just really me just being curious. And so thinking about if you're increasing your pain threshold, like, is that a good thing or a bad thing when it comes
Well,
to just thinking about like all of the executive functions that are required for an ADHD or to even access support and help? is extending the time in which that they feel pain or can tolerate pain, or increasing that threshold. Is
Yeah.
that a good thing or a bad thing? Like, does that delay treatment for the ADHD?
Well, so what we find is that you want to have a perfectly balanced threat detection system. So let's imagine you go to the airport. It's right after 9/11. For months after that,
Mm-hmm.
everybody's getting checked at the airport. Every innocent looking person to every uninnocent looking person, everybody from the sweet grandma to, all people are getting frisked and checked. Well, that's not
Mm-hmm.
productive to expect every sense is a threat, right?
You're right.
That so people with ADHD, autism have I like to put it as a hyper threat detection system. And so it's like a dog who barks at everybody. No, 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 that's just Dr. Lenz. Quit barking. Well,
Mm-hmm.
he's friendly once he gets to know you, but he barks at everybody. And so
Yeah.
that what happens is that is disruptive in your life is if you constantly feel something is injured, it
Mm-hmm.
literally feels it's just as injured as if you did have some nail going through your head and you're some pain or your hand's gonna freeze off.
Right.
But when there isn't tissue damage, to be constantly feeling like there is, that causes severe amount of distress. There are rare conditions where you can't feel and you've lost sensation, and then you look at tissue damage to sometimes nerves in those who have what's that condition? Forget it's Old Testament way back, and we still have cases of it, but
Oh,
leprosy, where they can have damage, and so they may not feel, the nerves may get injured, may have tissue damage because you can't feel things. So they're walking around, and you break an ankle, and what you're saying, well, gosh, what if you broke an ankle? Now, what it
uh-huh.
turns out is if people break an ankle, the ankle is healed. And then often what happens is, well, my fibro started when I broke my ankle, and the doctor said, you're fine, it looks good. And now, 2, 3 months later, it feels severely in pain, but everything lines up. There's no injury. It looks normal. If you would share it with multiple orthopedic doctors, they'd say that's a well-healed fracture. They should be recovered. But often then there's an injury, and now they have prolonged injury. The on button gets turned on, so to speak. And similar to somebody who may will look at PTSD, that threat detection is good in certain situations, but often the threat for anxiety when they come into a safe place is highly disruptive, obviously, to
Right.
have that. So I've not had any cases where that would make people have left. Now, if you want to use an analogy, is let's say the soldier in the battlefield, and they might be having an injury,
Mm-hmm.
but they have to get to safety. They're in danger, from that classic kind of situation. If somebody is exercising, exercising decreases that threshold as well. So that
Mm-hmm.
actually is looking at lifestyle medicine and looking at a holistic approach. Being regularly active actually turns down the volume control. So one way to look at this NOCI um, plastic pane is like a volume control for a guitar amplifier. We strum the guitar. You can just have it in my room here and you can hear it. You put it into an amplifier, and that sound can obviously get expanded so that the neighbors outside could hear it, right? Or the whole house can. The volume control in people who have ADHD or neurodivergent autism tend to be turned up. So light pressure gets amplified. So there are many
Okay.
things that can turn that up and down. So having a supportive environment that's sensory supportive, having regular exercise. Now, when you look in, they overlap with ADHD. Often when kids become adolescents, um, who have ADHD, their activity often, on average, decreases faster than those without. Now, the ones who do not, guess what they're doing? They're in sports. They're in sports, right? They're
Oh,
in
yeah.
they're in dance. They're in gymnastics. They're maybe have a job where they're constantly active, and they're like um, treading water really fast, and that's normal, and they don't have a problem. And then eventually everybody, even the best athletes, have to retire from their sport. They're no longer professional athletes, or they get an injury. They get their ACL. Now they're not training on a Division One sport. Now they aren't working out 3 to 4 hours a day, and suddenly they can't move, and then the pain amplifies. So that's but getting back to often treating ADHD is the
Yeah.
cognitive fatigue, the overwhelm, there's that emotional dysregulation.
Yeah.
Emotions affect our interpretation of threat and pain and anxiety, all are this overlapping thing. Does that help make sense of things?
It does. That makes so much more sense. And thank you for clarifying that, because I was like, wait a minute, is this going to cause like other problems? But it really just sounds like, if you treat your ADHD, then you can increase your pain thresholds, and then you can function in life, but then also be more productive, because you're not constantly being disrupted by what you're experiencing, whether or not it's perceived or real.
And it's both
That's the summary.
so it's probably they're both real. We both know when we look at functional MRIs of people with and without fibro, is the same part of the brain for
Yes.
pain is activated, but it's the threshold at what they're activated, right? And so that is gets to this very fine tuning that
Yeah.
our body has, how incredibly designed it is, and this slight shift can cause problems. And it can be severely distressing for people who are going through this. And
Hmm.
yet, on the positive side, if you can recognize this coexisting issue, having a ADHD style brain, um, like help support that. And then, so I could keep talking more, but I don't know if there's other
No, yeah, I
things
have
you're wondering
a
about.
question around like, so I mean, because I feel like there's you and probably like five other people in the world that like know this. How do we get either more medical professionals to be more knowledgeable of this connection, or how do we empower and encourage individuals with ADHD to be able to ask different questions to their doctor and kind of force their doctor to do some research?
Yeah, that's exactly a great question. I was talking to a couple patients of mine. I'm going to be interviewing Dr. Skoglund, and they found me through the podcast. And Dr. Skoglund wrote Women and Girls in ADHD, Getting Them on the Radar, right? I don't know if you've heard her
Mhm.
speak. Um, and they said to me, these were two women, probably in their 30s, 40s, were being treated. And they said, how do we get more people to recognize this?
Yeah.
One of the women was in her late 40s, and I was also seeing her daughter, who was 14, and both were kind of within, daughter gets diagnosed, what mom's right after that. Mom
Hmm.
sent a cousin in, mom's going to be sending, because of this family tree of people coming in, and she has, it's as you could imagine, the older you have when you get diagnosed, it can be highly emotional when you start to connect the dots and you review your life experiences and understand it. And as I talk about on the podcast and with patients, it's like, well, so neat when you can then help the younger kids. Now the 14-year-old daughter doesn't have next 30 years of same struggles that mom had. She can hopefully get
Hmm.
awareness. These were two individuals who have coexisting autism type
Hmm.
brains too. So that added an element to things. Um, I think one of the things, and it was talked about at AppSARD, and we're going to be doing more podcast interviews about this. When I think a big step will be if and when stimulants are declassified from a level 2 to a level 3. Until that happens, there is a lot of anxiety
Hmm.
about treating ADHD, because the number one treatment for medications is a stimulant. It's
Yeah.
what the gold standard, and then getting support from coaches to help relearn things that they didn't learn about how to do life, because
Hmm.
all these life skills, study habits, or executive function skills that they need to learn or relearn. I think that's going to be one step. So that was a kind of a sentiment, like, how can we help that? And because I think there's a lot of doctors who are nervous about it. There's not a lot of doctors nervous about prescribing Ozempic. There's not
Right.
a, and there's a quick uptake on that, right? There, um, and yet if we look at the positive impact, I just did a recent episode on treating ADHD. 43% of adults who have a BMI of 40 or over have ADHD. Chronic pain is connected with obesity. Guess what happened in the study where they treated their ADHD? They had on average about a 13, 14% weight loss. Guess what the average reduction in weight loss is when you treat with Ozempic? 13 to 14%. What if you added, what is the average reduction in weight when somebody goes on a healthy, whole foods, plant-based diet? Oh, about 13, 14%. What if we gave somebody with ADHD who was obese and had treated their ADHD and treated them with a whole food plant-based diet? That happened to a patient of mine. I have an episode about this. Her name's Sarah. That's their pseudonym. It's not a real name, but she went from 300 pounds to 220 pounds by implementing a healthy whole food plant-based diet. I saw a patient today who was referred by a
Mhm.
therapist like you, whose husband came in. We were talking about um, he said, instead of the problem list in the medical chart, non-compliant. He has uncontrolled diabetes, heart disease in his 40s already. I see non-compliant in the chart. I reframe it. And this is a new word I learned at the conference. Maybe you know this. Inconsistent in taking your medications. And that's also the kid in school who is inconsistent in doing their homework, inconsistent in bringing the homework back to school, inconsistent
Yeah.
in cleaning their room and helping out. So recognizing that part of health control, if you can use that executive function to help just manage other health conditions, that you get some genetics that put you more prone to diabetes, more prone to heart disease, that
Yeah.
require an even healthier diet. So all of these are connected.
Yeah. And I mean, I'm glad that they're starting to reframe and use different language because non-compliant never really sit well with me either. Um, Especially when you start to factor in their differences. It's like, it's not that I'm being intentionally um,
Difficult.
trying to not do this, right? And not being non-compliant, like being compliant, like I'm not intentionally trying to not do this. There are executive function challenges that get impacted, and so it causes inconsistency. Um, and yes, I'm glad that they're changing that language for sure.
Yeah.
Um,
So I guess that's part of that's why we do these conversations today, to get the message out. That's part of
yeah,
why I did the book. That's why, just from a grassroots trying to do this, I don't have a marketing campaign. There's no sponsors. I don't take a bunch of supplement companies that have minimal, if any, benefit, and try to promote this to make money off this. This is just medications in combination with treatment and education to help. Um, I think the problem is, and this is kind of the nature as I've learned, and I work with medical students and residents, is the medical world. If you have a complex problem, where do you go? You go to a specialist. The
hmm
problem is, this is a problems that overlap with multiple organ systems. So a urologist who's treating irritable bladder syndrome is not going to be diagnosing and feel comfortable recognizing and diagnosing ADHD. Now, they might, if they start to have their own daughter get diagnosed
hmm
who's got this, and then they recognize, hey, when she got it treated, her irritable bladder got better, and they may be aware, and they might be keyed in and say, hey, I know a doctor who has this. I think you might have this. I'm not going to diagnose and treat that, but recognize this. I know within the area around where I work, I have referrals from other doctors who recognize this within the primary care. Actually, I'm primary care, but a lot of people see me because they consider me their specialist. If you go
hmm
to chronic back pain, the doctors you see often are key to doing instrumentation and physical, along with physical therapy, but they're not trained. A
yeah.
physical medicine rehab doctor isn't usually trained in recognizing ADHD. Although I sat next to a woman at the conference who was a physical medicine rehab doctor whose
Oh,
son
nice.
got diagnosed, and she found out, and the son, who was an adult son, this woman probably around 60, said, oh, I don't have ADHD. And then it turned out she did have ADHD. She got treated, and now she's learning all about this. And we were conversing about her story, but it took her son and herself to get diagnosed to recognize that she's late in her career. So my hope In the world of medicine, it takes 17 years for some commonly accepted medical basic science information to be routinely established in healthcare. And how can we accelerate that? Well, hopefully we can with social media and information like here with good evidence-based support, good
Yeah.
support, education and understanding.
I mean, and honestly, I mean, I feel like I'm getting to the place where I just feel like ADHD or a conversation around ADHD and some basic information about it should just be a part of everybody's curriculum. Um, and my training initially was in social work, and we definitely did not talk about ADHD. And I mean, it was also a while ago when ADHD wasn't necessarily such a hot topic, so that might have something to do with it. But I also really truly believe that there are so many connections or so many challenges that come along with just how the brain is just wired differently, that there needs to be some level of understanding of that from the beginning when people are starting these programs, or at least throughout the program, because even when you're learning about how the brain works or what your specific specialty is, once you start talking about treatment, and then once you start talking about behavior changes or anything that requires the patient to implement something, being able to have a conversation about taking the approach and recognizing that that individual has ADHD and their process of implementation may be different. And so if you're expecting them like, oh, just take this pill every day, that may not happen. And so that's not necessarily the conversation that you need to have with the ADHDer. And so it's about putting in different types of strategies to help support that behavior change. But if you don't know about it from the beginning, then you're just providing advice that doesn't work. And then you're wondering why people are having all these problems and challenges.
Yeah. There was so it's this comprehensive approach. And the other thing in medicine, it takes more effort to do this. Um,
Mm-hmm.
it's easier to just refer. And I think a lot of times in the primary care world, which is the best suited to handle this, um, if your mentor didn't train you this way,
Mm-hmm.
then you don't even come out of this. And then if it was just using Cymbalta, if it was just using an Advair for your asthma, and there was no stigma that it's a controlled substance associated with this, but now the data is there's a study that will be likely published. It was published as a poster at the conference. It was over 1 million people, I believe, looking at a huge database of people who had a substance use disorder, alcohol use disorder, marijuana, cocaine, heroin, opioid use disorder, if we think of that.
Mm-hmm.
And so doctors, and these were like teenagers to age 65. And what they found is that, there has been this kind of feeling that you should probably treat somebody who has ADHD and a stimulant use disorder in their history with a stimulant, for example, because that could put them at risk of developing an addiction. I just saw a patient today in his early 20s who had issues in elementary school, but they were worried about addiction, so they never got treated, and then later in high school worried about addiction, so they didn't really push meds. Now he's had got an alcohol use disorder,
Mm-hmm.
first DUI in therapy, but getting help now with that. But so they studied this group, and what they found was about half of the people were continued on stimulants with the
Mm-hmm.
known diagnosis. The other half weren't. But there was a 16% increased mortality rate in those who weren't treating their ADHD with stimulants. They had
Mm-hmm.
higher rates of intubation, which would be drug overdoses, higher rates of Suboxone use, and then much lower rates of connecting with clinicians, whether that's mental health support or doctors. Those who were treating their ADHD were like 4 or 5 times more likely to be connected with care, um, getting counseling, getting therapy, seeing their doctor, getting medical management. So it's huge. The
Mm-hmm.
patient I saw today, he could be dead. I saw another patient who's was adopted, and both his parents he knew were dead, and they both had alcohol use disorders. That's what he knew of them, that they had past. And highly likely they both had untreated ADHD and shortened lifespan. So it's more than just getting a decent grade to get through med school or get through
Right.
college. It impacts, as you know, so many layers. But it's a little bit like if we can get it to the metaphor that if the medication is like wearing glasses or a hearing aid, if you need hearing, that's just tuning it down. If you want to use another metaphor, having, let's say you have a hearing aid,
Hmm.
right? But the volume control is turned up.
Hmm.
And you're like, and maybe if you have relatives who have hearing aids, it's like, it's too loud, or
Yeah,
you got to
everybody's
turn down
screaming.
the volume. Everybody's yelling, right? And it's like, well, what if you're missing somebody's cry for help? Okay, you might hear that cry for help out in the other
Hmm.
neighbor's yard, but in the meantime, everybody seems like they're screaming in your ear.
Right.
And that's what it can be like with these chronic pain syndromes. So part of it is just calibrating. I just came with that analogy off the fly here. I'll have to use it.
It's true. I mean, it's true. And, that's how I view accessing supports too outside of medication. And feel the same way, especially in the context of work. It's there needs to be a shift in the way that you're managing people, in the way that you're viewing your employee, because they may not be doing the work the way that you want them to do the work or the way that you expect people to do the work, but the work is still getting done. And so that change in perception is so necessary for when it comes to working with people that just operate and have different brains. Um, and the same thing around the perception of using medication, like it's necessary. And I always think about college students, and like when you have the college students that don't have ADHD but access Adderall, and then you have the college students that do have ADHD and accessing Adderall, and the impact that it has on the two different teenagers
Yeah.
when they're trying to get work done. Or the same thing when I think about caffeine, like I can drink a cup of coffee and go straight to sleep. And it doesn't impact me whatsoever. Um, but other people, they'll be up and be wired and up all night.
Yeah. Yeah. And that's one of those things I've learned over time, that historically, like, caffeine is connected with getting migraines. All right, very high levels of caffeine, we think of caffeine withdrawal, etc. That's kind of a often a common understood thing. But if you look at reverse engineering your understanding, if you look at the root, is caffeine, high caffeine consumption, due to untreated ADHD? And if we look at it as underlying ADHD as being a huge factor that leads to the caffeine, so you get this
Mhm.
double connection, right? And I never in the past ever thought of somebody who drinks, a pot or two of coffee a day, and I'm like, stop drinking coffee. Well, I need it to, you know, and your training didn't even recognize that could be somebody medicating their unrecognized ADHD. Now, when I see that, um, it makes me pause and ask those questions.
Mhm.
But I guess getting back to medicine, in the medical world, getting more interest, it's like I presented this at my medical system, Frederick Medical College continuing education conference for primary care doctors, gave a talk on this, tried to cover everything in 30 minutes, give all of this information, and some NPs there. And I think it's like, oh, that really changes the perception that you have to be humble to reevaluate your prior assumptions. And often, I have an episode on this, but do you know the most stigmatized medical condition by surveys of medical students and doctors over decades has been, the most stigmatized medical condition is
Oh,
fibromyalgia.
oh, really?
It's the least, it's the most stigmatized, least prestigious by medical conditions. Like, you know,
Oh, that's so interesting.
like leukemia is pretty prestigious. You're
Mhm.
rescuing somebody who has heart disease. Like, hey, let's help them with
Yeah.
that and cure them. But oh, aren't those fibromyalgia just a bunch of worried middle-aged women who are just whining and hysterical and, you know, gosh, it's just a little pain with their periods, and what's the big
Yeah.
what's
Well,
the big deal?
yeah. And
And
if men
and it's a
were experiencing it, we wouldn't be having this conversation.
I found out that I'm one of two men on the special interest group for women and girls with ADHD. And when I met Dr. Littman, who you probably, I'm sure, know, at the conference last year, she's like, "What are you doing here?" And I said, "What do you mean?" "Well, you're a man." And I'm
Mhm.
like, "Well, my mom was a woman, and my wife's a woman, and my two daughters, and yeah, they're young women. Why wouldn't I care?" Half my practice, and if you look at fibromyalgia, often the ones coming to the doctor are more likely to have be women and
Mhm.
girls. So I often see a higher percentage. When I often doctors may say they specialize in women's health, but if you don't recognize ADHD in women and recognize the endometriosis and PMDD and vulvodynia might be overlapping with a different central nervous system, and that includes ADHD, you're not being comprehensive. It isn't just giving you an IUD and knowing the different birth controls, but it's also being able to understand other aspects that affect women.
Yeah. I mean, and that makes me think about, different questions that we should be asking as women with ADHD to our own doctors, to our own gynecologists, and to our own primary care doctors. Like, how much do you actually know about ADHD?
Well, one of the things that, you know, and I'm probably going to do an episode. I have a listener who was on the podcast, and she almost says, "I almost just want to move to your state so you can see me," because she lives pretty in a bordering state. And she went to a recent doctor's appointment and talked about fibro and trying to struggle with things. And she said, "Hey, I know there's a podcast. If you want to listen." "Oh, yeah, there's a lot of
Mhm.
podcasts." It's like it was kind of ho hum. And here she's trying to educate, and that left her frustrated, as if the doctor wasn't like, well, tell me more. I'm always eager to learn. And I guess, as you can tell, I'm a lifelong learner, and you
Mhm.
want to have that growth concept. I had a mentor in the early 90s being my pre-med program called Target MD, and he said, you know, every 7 years, half of what you learn changes. And he said,
Mhm.
you're going to learn a lot from your patients. And I thought, how can things change every 7 years? But he was a seasoned doctor. I wasn't going to say no, it's not, and I just was humble and say, yes, sir. I'll just keep my mind always ready to learn new things. And this has shown so much in so many things: how we treat things, what are the medicines, how we understand the illness, things that didn't even exist. Like
Mhm.
autism and ADHD supposedly couldn't exist together. Now we understand that most people who are autistic also have ADHD, but that used to be exclusionary until 12 years ago. So
Right.
having these
Right.
increased awareness, so hopefully it would be standard part of care. I'm also a lifestyle medicine doctor, so I encourage a healthy, whole foods, plant-based diet, good sleep, avoidance risky substances, good um, uh, stress management, good sleep, all of that. They're trying to
Yeah.
add that to a medical school stuff. Plus, they have to learn all of the other things. It's often a lot to learn. I'll share one story. I had somebody who med student that I was talking to in her third year, and she said to me, asked what she was getting into for like what kind of stuff, because you're doing rotations. What do you think you're going to be for a doctor? And she said, well, I've said health issues. And I said, oh, well, she looked very healthy. Well, somebody looks healthy. We call those invisible illnesses,
Mhm.
and I knew right away it didn't look like she lost her hair, was dying from cancer, beautiful young woman. And so right off my head years up, it's like, well, I got I got POTS and Ehlers-Danlos, and nobody really understands it and helps. And I said, oh, actually, I kind of specialize in that. I have a special interest in that. I actually wrote a book about those related things, and I have a podcast about that. She's like, what?
Yeah, so we need to get more people to like listen to your podcast and to read your book. And also, you know, to remind women to be able to advocate on behalf, because most likely your doctor may not actually know this detailed level of information, because it seems like Dr. Lancier is like one in a million. So we might need to, or like one out of five rather. And then, so we really need to be able to educate ourselves, and then also, uh-oh, educate ourselves, but then also to be able to provide resources for our medical teams too, so they can get a deeper knowledge and we can get some holistic care. And so can you tell us the name of your podcast and your
Yeah.
book?
Yeah, it's both of them the same name, Conquering Your Fibromyalgia. The book subtitle is Real Answers and Real Solutions for Real Pain. The longer subtitle would be Real Answers and Real Solutions for Real Pain, Fatigue, and Brain Fog.
Mm-hmm.
Um, and one of the things, when you talk about finding a doctor, this person said, I should do an episode. How do you find a doctor? That's the most common question I get. I'm
Mm-hmm.
in Maryland. Do you know a doctor who does what you do? I'm in California. I'm in Florida. I'm in Texas.
Yeah.
I'm in the UK. Do you know anybody? Do you do virtual visits from Australia?
Right.
You know, and what I found is you might have to piecemeal it. For example, if you recognize that you do have ADHD, and maybe
Mm-hmm.
hopefully your doctor's willing to learn and they just don't know. Maybe they say, here, listen to the podcast. My medical students who work with me, they're just learning so much. The medical student, the third year, said she wants to try to fit in a rotation just to see how I work with patients and interact so we can help with that. But you might then have to understand and say, okay, I might have to go to an area where there may be an ADHD type clinic or doctors who are specializing in that and recognize then that's part of it. The ADHD world is learning a little bit more, but they aren't thinking of chronic pain. They're thinking of doing well at work, getting your degree done, managing your house, and they often aren't seeing the patients necessarily for chronic pain. Although when we know the most common diagnosis in Dr. Young's psychiatric clinic, which is a big clinic with multiple providers, there was chronic fatigue syndrome. So hopefully more, and then be pleasantly surprised if your doctor has learned, have this connection and has this help, and hopefully they will be willing to um, manage those. I think that's kind of the somewhat pathway forward if you're having chronic pain. Um, and then I do talk about the role of lifestyle, the role
Mm-hmm.
of recognizing other coexisting issues with that. And if you want to connect with me and you're in Wisconsin, I can see you because how our stuff. So I could see you if there's anybody in Wisconsin. Um, we do virtual visits within the state. You have to, with how the contracts work with licensing. But so, but hopefully you can start seeing the connections and have the confidence is, okay, there's a connection, and maybe treating the ADHD consistently is
Yeah.
going to help with you overall implementation of a comprehensive, multifaceted approach.
Yeah, no, this was great. I'm so glad that you were able to come and talk with us today. And I know you're coming back to, I think next month. I don't remember the date off the top of my head. But you're going to be doing something a little bit more detailed for the women that are in my Thrive program. So just a little mini commercial. If you are a woman with ADHD and you're looking for some additional supports and be successful in working in life, then I do have a group coaching program that is available. And so we'll have guest speakers like Dr. Lenz come in and do some more Q&A and to be able to really get some detailed information in a smaller setting. But also we have weekly group coaching in addition to, I also do some weekly lessons around different topics related to ADHD. So this week we talked about working memory. Earlier, what's today, Tuesday? Yeah, earlier today, we talked about the challenges that come up with working memory and some different strategies to kind of put in place in order for you to be successful with some of those challenges that you're experiencing with that. So there's some self-coaching and some workbooks that are available as well. So if you're interested in joining Thrive, just let me know, send a chat message, and we can get you started. But end of commercial. But I really appreciate you taking the time to come here today to talk about this. This is such an important topic. And the replay for this will be on YouTube. And we'll put, actually, if you can send me all of your links, then I will make sure that that goes in the show notes, I guess. You want to
Oh,
call them show
sure.
notes. So that people can make sure that they access it. Because I think you're offering some really good resources that even if people can't access you directly as a patient. They can access the information that you're sharing, and then they can share that with their doctor so that they can get some real support, and that their symptoms and their experiences aren't overlooked, and they can get real treatment. And so I appreciate you doing that.
Yeah, and I don't really have a huge Instagram stuff out there yet, so this is my actually first Instagram live. But I do have some interviews and on the podcast platforms, and most the biggest ones. You can access that there. I do have some interviews also that I've done that are on YouTube as well, looking at a comprehensive approach. And if you like this, feel free to
Yeah,
connect with me.
contact him. If you are looking to interview somebody around this topic, please reach out to him down here below.
Okay. Yeah.
As well. I'm also about, highlighting what the other work that people are doing in this world. Like the more information that we have, the better is how is the perspective I take. And so, please make sure that you reach out to him, access his materials, share his materials with your own, doctors that you're working with, and to ensure that you're all getting support, and we can spread the word about the connection between chronic pain and ADHD, so we can do something about it, because if people don't know, they're not going to do anything about it, for sure. And then I'll connect with you too after this too, to get the links to some of those research articles that you had mentioned earlier in the conversation from the conference, if you don't mind sharing them. um, I would like to read them myself, actually. I'm kind of sad that I missed the conference now.
Well, it's going to be in DC next year. Did you know that?
Oh, it is? Oh, great. That's even
That's your
better.
backyard, right?
Yes, that's even better. That's perfect.
I was a little disappointed. I'm like, January? Who wants to be in DC in January? A little bit warmer than Wisconsin, but it's not going to be. It's
Yeah, well,
not
that's
San
great.
Diego.
Well, next conference, I will be there, so I get to see you in person.
Yeah, yeah, that's
Um,
my hope that if anything goes planned, I'll be there. It's a great conference for
yeah,
those. It's for clinicians, healthcare, some people who work. It's not so much a patient who's living with it. It's more targeted unless you're a patient and a clinician who
hmm
just really wants to see the who's who and the experts in the world of ADHD and some of the latest studies. So it could be somebody for you going to. I think there's another bigger conference that probably is a little more geared towards
yeah.
uh, people negative.
There's an ADHD conference that Chad and Ada and ACO do every year.
Hmm.
So that's going to be in Kansas City in November, and then I think they're doing a virtual one in a couple weeks in March, um, March as well, and that's a little bit more like if you're living with ADHD friendly compared to the outside one. But I just like information. I like research, and
Yeah,
so it's just I'm
yeah,
just working that way. So I like to see behind the curtain and like what people are actually doing and taking the time to do that research. I don't want to do the research myself, but I do appreciate everybody else that enjoys the research and the writing. Um,
yeah. It's neat. When you look around, you're like, oh, these are all the people. If you've listened to like Attitude Mag, you've read articles. They've Dr. Brown was there. He's just sitting next to him. Just all these people that are the ones who've done research, who I've learned from them all
yeah,
of the research and clinical experience as a clinician, but not researcher. I think I'd love to put more of my cases and case reports and case series together to help with that. But if I can hire or have a med student do that with me for a month and try
yeah,
to collate
yeah,
that. But well, again, thanks so much
yeah.
for
Thank you so
having
much.
me.
No problem. And then I will talk to you probably later this week about what's going to be happening next.
Sounds good.
Okay, thank you. And thank you everybody for joining our conversation today. And I hope that you got a lot out of it, because I know I did. I learned a lot of new things that I did not know. I don't know everything about ADHD. I know a lot of things, but I don't know everything. And so I have people come on here to teach me things too. So I appreciate that. Um, but everybody have a good night or a good afternoon, depending on where you are in the world. And thank you so much.
But
I'm going to say bye.
bye
Bye.
bye.